Well, good afternoon and welcome back to session 4 of our Lurie Children's Pediatric Roundtable featuring the Special Infectious Disease Department. And I'm Chad Worley. I am the physician liaison for Lurie Children's, and I cover the north suburbs and the north and northwest suburbs and north part of the city. Said that so many times today, it was, I confused myself. Anyway. So I'm here to welcome Jennifer Howe, and she is going to be talking about HIV prevention, birth to young adult, and I know many of you are excited about this today. So, but before I send it off to her, I would like to remind you that you can go ahead and ask questions in the question room, and if you'd like, you can go ahead and raise your hand, and I can take you live after Dr. Howe's presentation. And just a reminder that this is being recorded, and I'll be sending out the link to everybody afterwards. But without further ado, Dr. Howe, I'm going to go ahead and make you a presenter, and I'll let you take over from here.
Okay, great. Thanks so much. Thanks for joining me, everyone. I'm going to shift a couple clicks away, and then I'll be on my screen. Can everyone see my screen, hopefully? Yep.
We sure can. Yep. Have a great time.
All right, great. So again, we're going to be talking about HIV prevention, and I lost my screen. Hang on just one second.
We see your screen
now. Can you still see it?
We sure can. Yep. You can go ahead if you can see it.
Okay, I think, well, let's try here. Now I just X'd myself out so I don't have to look at my own face. All right, so again, we're going to be talking about HIV prevention from the minute you're born all the way to young adulthood. I am going to make sure that you all know I don't have any financial disclosures. And I think I'm hoping by the end of this, 20-30 minute time with me that you will be able to recognize who's at risk for acquiring HIV, understand a couple of different modes of HIV acquisition, and identify optimal HIV testing diagnostic strategies based on the potential for acquisition of HIV. And then also, I'm hoping that you'll be able to identify the best options for preventing HIV transmission, both just across the lifespan, from birth all the way up into maybe 24, 25 years of age, depending on your practice. So this is just a quick slide kind of showing you, goodness, the entire lifespan, starting from the in utero mode all the way up until the young adulthood. And these are two kind of primary areas that we're going to focus on where one could potentially acquire HIV, both in the perinatal time point and then later on in life. So let's talk about perinatal HIV exposure first. I think the first thing that we all try to do is risk stratify when we're trying to manage perinatal HIV exposure. So once we can determine whether or not they're high or low risk, then you can sort of go on to determine the proper testing algorithm. And after you finish doing your testing algorithm, you can simultaneously figure out which appropriate ARVs to give. And here is a little slide showing you the difference between a high risk and a low risk infant. So basically, we'll make it easy. High risk is at least one of any of these following. And I'm highlighting in orange here so that you can hone in. So infants born less than 33 weeks gestational age, if the mom had a detectable viral load after 28 weeks of gestation, that puts them at high risk. If the infant was born to a mom who did not receive any antepartum antiretroviral therapy, that automatically puts the kid at high risk. If the mom started antiretroviral therapy, but after the first trimester, that also puts the infant at high risk. Or if the mother was someone who seroconverted or became infected during her pregnancy. And of course, right now we test moms first trimester and we do one more in third trimester. So if you're seeing that the mother seroconverted between those two time points, that puts the infant at high risk. And lastly, if the infant was born to a mom who was diagnosed with HIV just during labor or just in the postpartum period, we would consider that infant high risk. And everything else can be low risk. So what do we do in terms of testing? Once you've figured out whether they're high risk or low risk, you have to choose between some of these tests that we have. The first one there is an HIV DNA PCR. So that's a qualitative answer of whether or not we can detect HIV DNA. The RNA PCR is quantitative, and that's your viral load. And then there's a third test here, which is a total nucleic acid test. And I'm not sure which sites and institutions still have that, but that is a third sort of diagnostic testing assay that we have available to us. If your infant was born to a mom who acquired HIV outside of the US or Europe, they could have, meaning that mother could have a non-clade B viral type. And so I'm going to give you an example. A mom comes to you, she's immigrated, or she was diagnosed with HIV in sub-Saharan Africa. Then here we would like to make sure that the testing you do in this infant is either an RNA PCR or a total nucleic acid test. So once you've decided what kind of test you're going to do, we also want to know how frequently you're going to test. And so that, again, goes back to whether you are a high risk or a low risk baby. So if you're a high risk, you're going to test more frequently. So at birth, 2 weeks, 8 weeks, and 4 months. And low risk does not get a birth testing done, but gets one done at 2, 6, and 4 months. And so the orange highlighted there is just the differences. So you can see the testing frequency differences between high and low risk. So then what do we give? What do we give for these infants? And again, that is going to be determined on whether or not the kid is high risk or low risk. And what I'm showing you right here, we're going to focus in on the low risk because that's easy. That's Zidovudine for 4 weeks. It gets a little trickier if you're high risk, and so we'll go with each of these 2 regimens. So the first one, the recommended one, is Zidovudine plus Lamivudine plus NeverPeen, so 3-drug regimen. The alternative to that is Zidovudine, Lamivudine, and instead of NeverPeen, it's raltegravir. I realize this may be alphabet soup to some of you, but the key difference here is the swapping out of NeverPeen and raltegravir. How long do you give these for? Well, if you're high risk, you're going to stop those bottom 2 drugs, the Lamivudine and the NeverPeen, or the Lamivudine and the raltegravir at 2 weeks, but only if your birth PCR comes back negative. And then you'll continue the Zidovudine out for a full 6 weeks. And remember, this is 6 weeks, not 4 weeks like the low risk baby would have. We're going to continue on. These slides here are just going to go through the dosing of Zidovudine in a low-risk infant. You don't have to memorize any of them, but I'm putting them out here so that when you need to come back and look up a dose, it is here. And so, again, Zidovudine dosing is parsed out depending on the gestational age or how premature the baby is. And here we have weight band dosing if you're 35 weeks or older, but if you're younger, we go by a milligram per kilogram dose, and depending on the age of the infant. Zidovudine dosing in a high-risk infant is pretty much the same, so we've added that here, except remember, it's birth to 4 to 6 weeks of age in the high-risk infant, and then more than 6 weeks of age, the AZT is going to be given at that 30 to 34 weeks gestational age. And then the last one, depending on how old the baby is, right, because the high-risk infant is going to need a full 6 weeks. There in the orange brackets on the far right is also what you'll get. So then how about Lamivudine? Same thing, no need to memorize any of these, but I'm laying them up here so that you can always refer back to them if you need. But this is also based on the gestational age of the baby. And if the baby is less than 32 weeks, we would highly recommend consulting pediatric ID because we don't have very good data on the pharmacokinetics of lamivudine down to less than 32 weeks. So the dosing of NeverPeen and raltegravir, those are the two that are swapped out and could be interchanged. But the key thing to know here is that raltegravir cannot be given in premature infants. So in general, unless you have a term child, you're probably going to be stuck with NeverPeen. So these are the doses of NeverPeen that can be given. I'm just scrolling through them for you. And again, at less than 34 weeks, we don't have great pharmacokinetic data on how to dose NeverPeen, so we would highly recommend consulting a PEDS ID. Here on the right is a weight band dosing that is also available for raltegravir in case that makes it easier. And I'm putting this little slide up here just to show you that this is the booklet that we often give to our moms whose infants have been put on raltegravir. And this booklet is very complicated because there is a lot of instruction on how to dose these packets for the oral suspension that the women have to mix. So in some cases, if you have a term infant and you can use either raltegravir or NeverPeen, we will sometimes just go with NeverPeen just for ease of preparation and ease of understanding how to administer the drug for the mom. All right, so then what do we do to monitor these babies? Well, again, that depends on whether they're high risk or low risk. And so what we're highlighting here for you is just in orange, the only thing that is different in a high risk is that we would recommend getting a urine CMV PCR before 3 weeks of age. Otherwise, both high risk and low risk require getting a CBC at birth. And that's because, in particular, zidovudine can cause marrow suppression. And then the combination of zidovudine plus lamivudine, especially in your high risk babies who would need that combination is synergistic and can cause an even greater decrease in marrow suppression. This slide right here is just to show you a couple of handy websites. So at the bottom left there is the DHHS US Perinatal HIV Guidelines. That's at aidsinfo.nih.gov. And then the top right-hand corner, we're showing you the HIV pregnancy hotline for the state of Illinois. And that hotline, that number is open 24/7. If you call that number with any question, no matter what time of day, there will be a PEDS ID person to answer that and help walk you through any questions, as well as obstetric obstetricians with HIV knowledge. So please use that source as much as you can, especially if it's in the middle of the night and searching through a website is difficult. Great, so I'm going to keep moving on. The second part of our talk is going to be thinking through how to prevent HIV when the mode of transmission is later in life. And I'm just putting this slide up here so you can get an appreciation of the lifetime risk of HIV by patient population in the US. And by and far, men who have sex with men are at the highest risk for lifetime HIV acquisition. In fact, 21% of new HIV diagnoses are actually among youth ages 13 to 24 years of age. And again, as this bullet says, young males who identify as gay, bisexual, or have sexual contact with persons of the same sex are disproportionately affected. So who's eligible for PrEP? This is a quickie slide showing you that the 4 domains that you want to sort of assess to see if they're eligible for PrEP include whether the sexual partner even has HIV, whether they're MSM, whether they're a heterosexual male or female that does not ever use condoms even though they have a high-risk partner, if they've had any bacterial STI in the last 6 months, whether they're heterosexual, female, male, or MSM, we should consider them eligible for PrEP. Injection drug users as well, and we have 2 little bullets down there showing that if they equipment share, particularly in the last 6 months, or if they engage in sexual behavior which puts them at risk, we would consider them eligible. So how do we, go about doing some testing before you start PrEP? Well, the most important thing in this busy algorithm is that we need to obviously test for HIV first, because we do not want to give any kind of prophylaxis or PrEP if they actually have HIV, because when you have HIV, you need a 3-drug regimen or a full combination ART, whereas PrEP is only 2 drugs out of 1 class. And in addition for testing for HIV, you want to make sure they don't have acute HIV, because some of the older tests that were available, and hopefully this isn't as true today since we have the 4th-gen antigen antibody testing, but with the older tests, when this algorithm came out, we weren't always able to catch acute HIV with our usual tests. So what do we give? Today, tenofovir, emtricitabine, or TDF-FTC is one of the fixed-dose combinations. The other one is tenofovir alafenamide plus emtricitabine. That one is only approved for use in those practicing anal receptive intercourse, but both are FDA approved currently. What do you do before you start PrEP? Well, you'd want to, as we said, test for HIV, rule out acute HIV, do STI testing, in particular syphilis testing, gonorrhea, and chlamydia. We'd want to look for hepatitis B, hepatitis C, look for a creatinine clearance, and then a pregnancy test if this is applicable. And how often do we follow up after you've started the PrEP? The guidelines in the CDC currently recommend every 3 months, and in those 3-month intervals, you'd want to repeat the HIV testing each time, look to see if they're pregnant, assess for any side effects that they're getting from the tenofovir, emtricitabine, counsel on adherence, and again, you'd want to test for STIs again in case they're at high risk, or for those who are sexually active and report symptoms. Every 6 months, you'd want to get a creatinine to assess their creatinine clearance, and then an STI screen, even if they don't have any indication for symptoms. We screen them right away at every 6 months, and then at the 12-month mark, I would say yearly reassess the need for PrEP, because it's not uncommon that some folks may be eligible at one point in life, and then with different partners or different life circumstances, they may not need PrEP for another period of time. This last slide I'm putting up because I just wanted to let you know what's coming down the pike. The CDC said that new guidelines were going to be released in September. That I don't think that quite has happened yet, but hopefully in the next iteration of the guidelines, as well as in the upcoming future research studies that are going on, we should see PrEP 211, and that's pericoital PrEP, that's intermittent PrEP. Hopefully that will be coming out in the new guideline recommendations. In addition, long-acting injectables have been actively an area of PrEP research, hoping to see that come out. These 3 bottom ones, islatravir, broadly neutralizing antibodies, and vaginal rings, including dapivirine, are still under investigation, but we hope to see that soon. And really, I just say this to highlight the fact that PrEP research has really taken off in the last decade, and it's exciting to see what new is coming on in the pike out there. All right, I'll stop there, and thank you all for your attention. If there's any questions that I can take right now, I'd be happy to take them.
Thank you so much, Dr. Howe. That was fascinating. It was another great presentation that you all have been treated to today by the Division of Infectious Disease. If anybody has any questions, feel free to type them in the question box, or just go ahead and raise your hand and by your name. Oh, there we go. First one by Heather Hawkness. So right now there is nothing for event-driven PRP.
Correct. Yes.
Question. Okay. So there's nothing for that. Okay.
When you say event-driven, I just want to clarify what we don't mean post-exposure prophylaxis, right? We just mean pre-exposure prophylaxis.
If you'd like to go live, I can unmute you.
Sure. I just had a kid going off to college who said, well, what if I meet a partner, who sadly in high school ended up on PEP post-exposure, but after I mean, the hardest thing is deciding when to treat these kids almost. Like it's really tough. So, but I just wondered, like he wanted something more event-driven because he didn't see himself, I don't know, he didn't see himself at least seeing it regularly at the time he headed off to college.
Yeah, absolutely. I wish there were in the CDC guidelines right now, but there's a ton of stuff that is in the pipeline. I'm not sure for men though, but certainly the vaginal dapivirine rings, that is that's what people have been hoping to explore. In other words, insert it when you need it. Yeah, yeah.
Thanks.
Thank you. And then we have a question in from Mark Meyer. Do you think it's okay for PCPs to prescribe PRP? We are looking at starting a program at our FQHC. Is there a specific training required?
So I think it's absolutely fine and I say this because I had quite a career as a med peds primary care physician, and I was working at a Ryan White funded FQHC, and it was folks like me seeing HIV, people living with HIV as well. So I just think that as long as you all are able to follow these participants, I shouldn't say participants, these clients or patients, and keep track of them, because that is hard for any, whether you're a specialist or a subspecialist or a primary care physician. And I think that's what we always worry about, even when I see folks for PrEP, is that they fall off the bandwagon, they don't come back, and then I don't know if they're still taking it, and I haven't been able to get HIV testing. So, you know, as long as follow-up is there and that we only give discrete amounts of PrEP so that it's not like refill it forever, and that we're only dispensing discrete amounts to make sure we can do the HIV testing. In terms of training, you know, there's a ton of stuff on the CDC PrEP website that can be used for training without physically having to have someone come and speak, you know, sort of do an in-person didactic training. And I'm not actually sure right now whether particular policies are in place where FQHCs say, or, you know, some other institutions where they must be trained in a certain way. And that would be something we could try and find out for you. Yeah, I don't know if that helps answer your question in a roundabout way.
Yeah, he said, yep, we already have an adult PrEP program and have a good system in place. Just want to decrease age to teens, that's all.
Oh, so, gotcha. Yeah.
So
yeah.
Thank you for that. Thank you for that answer. And what else do we have here? Oh, is PrEP treatment, you know, Dr. Miner, would you like to go live? Maybe you could start a little dialogue here. Would you like to do that? I'll unmute you. How's that?
Yeah, can you hear me now?
Yeah, great.
Yep.
Go ahead.
Yeah, great. Thanks so much for the talk. I was curious if PrEP treatment is covered under the Illinois Minor Consent Law, because one of the things we're really looking at is issues around confidentiality. I believe it's considered a confidential service and you don't need parental consent. I just wanted to confirm that.
I believe it is as well. I guess the difficulty is if the minor is under the insurance, because we've run into this, is under the insurance of their parents, and whether or not, even though you're not going to disclose anything, right? Will the parents see a bill or something like that because they are the primary payer on the insurance? So that right, yeah. we've had that as a sticky point, and so we've just basically tried really hard with our adolescents and young adults to say, hey, we're not going to say anything, but just know that this might happen. Do you want to try and talk with, you know, your parents together with us? So I don't know if other folks have had different experiences. I would love to figure this one out. Yeah.
Yeah, thanks so much. I jotted your email down, so I may be emailing you for some more information.
Great.
Thank you for your participation. We really appreciate it. And Dr. Howe, I don't see any other questions out there. And I just want to remind folks that we are recording this, so we'll be sharing it back with you. And you can also share the link with your colleagues if you're so inclined. And Dr. Howe, you are also seeing telemedicine, correct?
Yes, we are at our clinic. So absolutely.
Excellent, excellent. Well, this is great. I really appreciate you coming on, and our team really appreciates everybody coming on today to see listen to Dr. Howe's presentation. But without further ado, I'll just go ahead and say thank you for joining us today, and we hope to see you again at 5 o'clock, where Dr. Raleigh will be presenting on Kawasaki disease, which should be a very well-attended event. So have a great day, everybody, and we'll see you soon.
Thank you. Bye.